Today I am going to discuss how to approach a child who has got pneumonia. So this will be a small presentation on how to, if you get a case of pneumonia, how are you going to approach that case. So first, in any case, when you are having a case, patient in front of you, first thing is the demographics. That is, the biodata of the patient. So the name of the patient, then age of the patient, then whether male or female, the address, that is where they are coming from. So that is important in some cases. Suppose you have a child coming from Lakshadweep. There are certain diseases or conditions which are endemic in Lakshadweep. For example, it is hemolytic anemia like thalassemia, or a child who is coming from the tribal area. Sickle cell anemia is more common there. So the geography distribution, there are geographic distributions for certain diseases. So it's very important to ask where they are coming from. So name, age, sex, then the address. The next thing is the address means you don't have to get the full address, just where they are coming from. Then comes the informant. Whether the informant is the mother, father, or the grandparents, or whoever is the caregiver of the child, and you have to write informant is the mother. Information is reliable or not reliable. Sometimes it may be somebody else who is bringing the child and he may not know much details. Then you say not reliable. Then coming to presenting complaints. So suppose you have a 1-year-old child who is a male child coming from Ernakulam only, and the presenting complaint is like this is a case of pneumonia. So probably the complaints will be like fever, cough, and breathing difficulty or fast breathing. So with the duration of this complaint, so maybe 3 days, fever and cough of 3 days, fast breathing of 1 day, like that exact presenting complaint and duration of each presenting complaint you have to write. Then ask about history of the presenting illness. So if the patient's first complaint is fever, what all will you ask? Whether the fever was gradual in onset or sudden in onset. How much was the maximum temperature? If they recorded it, they can say that fever went up to some 100, 101, like that, the maximum temperature. Then you ask for diurnal variation of the fever. Most of the fevers, it will be towards the evening hours in children that the fever will spike up. Classically, diurnal variation or evening rise of temperature is described with tuberculosis, but you will get diurnal variation of fever in many other conditions also. So you ask about diurnal variation. Then chills and rigors. So fever with chills and rigors is characteristically found in older children. Infants usually you don't find chills and rigors in infants, but in older children who has got a urinary tract infection or pneumonia or pus collection somewhere in the body, like that is abscess formation, sometimes cholecystitis, conditions like that, then malaria, there will be chills and rigor. So ask about history of chills and rigors. Then relieving factor. Most commonly, fever gets relieved with giving antipyretics, that is paracetamol, or by tepid sponging. So, but after a few hours, it will again spike. Fever will again spike. So, you ask all these details about the presenting complaint, that is fever. Then go to your second presenting complaint, that is cough. So, when there is cough, the peculiar thing in children is that they will not bring out the sputum. Most of the smaller children, they will swallow the sputum. So you will ask them whether it is a dry cough or is a wet sounding cough. That is, wet cough means productive cough, but child is not bringing out the sputum. Then how is the cough coming? Is it coming in paroxysms or bouts of cough? Characteristically described in whooping cough. Cough will come in bouts. Then when there is foreign body aspiration also, you may get bouts of coughing. So whether it is any cough is occurring in paroxysms, is there any post-acute vomiting, any diurnal variation of the cough, is the cough more in the evening hours or night time or in the early morning hours, that is characteristic of bronchial asthma. Then any postural variation of the cough, Is the cough more when the child lies on the left side or on the right side, or is the cough more in the lying down position and it is better in the sitting up position? So like that, postural variation of cough. Sometimes in bronchiectasis you might get a postural variation of cough. Okay, because the lower lobe bronchus on one side are affected. Then when the child lies on the opposite side, he might have increased cough because of the drainage of the secretions from that particular lobe which is affected by the bronchiectasis. So postural variation you ask. So fever, then details of fever, details of cough. Next is about the fast breathing. So ask the mother, has she noticed any fast breathing for the child? Has she noticed any chest indrawing, the lower chest indrawing for the child? So fast breathing, chest indrawing are all features of pneumonia. Then you ask about some red flag signs or danger signs of pneumonia in a small child, that is an infant or under 5 age group. So what are the red flag signs or the danger signs of pneumonia? One is drowsiness or altered sensorium. Then presence of any seizures or jerky movements, any bluish discoloration. Then ask for history of any stridor or any grunting. Then reduced urine output also you can ask. So ask about this. Then ask about other systems involvement. That is, other systems involvement means along with the fever, cough and the fast breathing, is the child having any urinary complaints? Is there any pain while passing micturition? Is there any loose stools? Is there any vomiting, any yellowish color to the urine? Like that. So ask about other systems involvement also. Then any audible wheeze also you can ask, and we are asking about any history of unconsciousness. History of unconsciousness because sometimes when a patient has seizures and becomes unconscious, they can aspirate and it can result in aspiration pneumonia. Then so this history you should take. Past history. In the past history you ask about similar complaints in the past. Any history of hospital admissions in the past. Whether the child has been given nebulizations in the past. That means this child may be having recurrent wheeze or bronchial asthma. So all these should come in the past history. Then perinatal history, you divide it into antenatal history, natal history and postnatal history. And since child is only 1 year old or below 5-year-old child, you have to get details of the antenatal, natal and postnatal history. Okay, so suppose it is a preterm baby or a low birth weight baby, these babies are more prone for infections like pneumonia. Then developmental history of the patient you have to take. That is detailed, you have to write the developmental history. Then comes the dietary history. So you know that breastfeeding always protects against infections. So ask about history of breastfeeding, whether the baby was given exclusive breastfeeds up to 6 months of age, and thereafter semi-solids was started ideally at 6 months of age. Okay, so early weaning is not good. Delayed weaning also is not good. It has to be started at 6 months of age only. And our breastfeeding should be continued up to 2 years of age. Then you ask about the total. You take your dietary history by 24-hour recall method. You have to take the diet just before the start of the illness. How was the child feeding, and calculate the total calories and proteins consumed, and compare it with the recommended daily allowance. So 1-year-old child approximately requires around 1000 calories, that is 100 calories per kg. That is the 1-year-old child. And according to the Holiday and Segar formula, for every year you can add 100 calories, or for 1 kilo you can add 50 calories. So if a 1-year-old child is 1000 calories, requires 1000 calorie, 2-year-old child will require 1100 calories. So per year 100 calories you add. So 2-year-old will require 1100 calories, 3-year-old child will require 1200 calories. Like that you can add up to 10 years of age. So that is holiday and Sagar formula, and also the protein requirement is given in the ICMR chart. So you have to compare it with the values in the chart. You have to learn it and compare it with the values in the chart and write. So proteins, calories are sufficient, and whether the child is getting enough of green leafy vegetables and fruits also. Take the immunization history in detail, and in immunization history there are certain vaccines which protect against pneumonia in the child. So what are those vaccines? One is the pentavalent vaccine. In the pentavalent you have DPT. So pertussis component will protect against pneumonia. Then you have in the pentavalent there is H influenza B also. That will protect against pneumonia. Then now we are giving pneumococcal vaccine also. So that also will protect against pneumonia. Pneumococcal vaccine is given at 6 weeks, 14 weeks and then at 9 months of age. So pneumococcal vaccine is protecting against pneumonia. Measles. Measles also, as a complication of measles you can get bronchopneumonia. So measles vaccine also protects against pneumonia. So ask about history of the vaccinations. Then in family history, anybody currently in the family, does he have any fever or any respiratory illness, any TB in the family, any asthma, allergy in the family, you can ask. Then comes the socio-economic and environmental history. You know all that. So some factors inside the house, social factors. Is there overcrowding in the house? Is any of the father or somebody else is a smoker? And what is the wood fuel they are using for cooking? Suppose it is wood, their firewood they are using, smoke will be there, and that can produce indoor air pollution. So these can all produce recurrent cough and wheeze and respiratory infections in children. So all that you will have to ask in a case of pneumonia. So that will be regarding the history taking. Then coming to examination of the case, any child, first thing will be first you will have to say a general comment. So is this child looking sick? So it's a sick looking child, or is looking toxic looking. Toxic means febrile and toxic. Excuse me. So is this child sick looking child, or the child is active and alert, not sick looking? Like that you have to put a general comment. After that you go to the vital signs. So when you go to the vital signs, you will take the pulse rate, respiratory rate, temperature and blood pressure. So and the most important sign here will be the respiratory rate for fast breathing or tachypnea. You know, a child, according to the ARI control program, you know, from 2 months to 1 year, a rate above 50 is tachypnea, and 1 to 5 years, if the rate is above 40, it is tachypnea. Above 5 years, above 30 is tachypnea. So like that you have to count the respiratory rate. Blood pressure is important. Sometimes child will be febrile, toxic and maybe in shock or impending shock. Impending shock means BP might be normal, but there will be tachypnea as well as tachycardia will be there. So examining the vitals is very, very important. After that you go for the head to toe examination. In every case you have to do that, head to toe examination of the child. And in this you can you look for any dysmorphic facies. Eyes, you will look for vitamin A deficiency. You can look, that is presence of white-out spots, any dysmorphic facies. Then is there any flaring of the ali nasi, any sign of respiratory distress is there in the child? That means the accessory muscles will be working. There will be suprasternal retractions, substernal retractions, subcostal retractions, then intercostal retractions or lower chest retractions will be seen. So look for signs of respiratory distress. So you do head to toe examination of the patient. After that you will do the general examination. Pallor, icterus, cyanosis, clubbing, lymphadenopathy and edema, generalized edema for the patient. So as you do in any other case. So sometimes if the child is very much hypoxic, you might find that the child is having a central cyanosis. Anthropometry, because you know that malnourished children are prone for infections. So the nutritional status of the child is very important. You know that in the preschool age group or under 5 age group, respiratory infections are the most common cause of morbidity and mortality in children under 5 years of age. So especially if their nutritional status is poor. So always check for malnutrition in a child who has got pneumonia. Even otherwise, in young children or below 5 years, usually they will get around 6 to 8 respiratory infections in a year. That is normal. 6 to 8 respiratory infections are mostly upper respiratory infections. So you know what the upper respiratory infections are, like pharyngitis, then our common cold or rhinitis, and otitis media, that is also upper respiratory infection. Then we have other lower respiratory infections are the pneumonias, the bronchiolitis, then the laryngitis, the tracheitis. All these are lower respiratory tract infections, and a child often gets 6 to 8 upper respiratory infections in a year. So now in anthropometry, you look whether the child is having malnutrition or not. So for that, you first always comment on the weight of the child. Take the weight of the child and write the expected weight. So it's a 1-year-old child, expected weight will be 10 kg. 2-year-old child means 12 kg. So you are adding 2 kg every year. So 1-year-old is 10, 2-year-old is 12, 3-year-old will be 14. And then another 2 you add, 4-year-old it will be 16 kg. Like that you can add 2 kg every year. So then you find out the percentage. That is the current weight by the expected weight into 100. And then you comment on the weight of the child according to the IAP classification. Normally means 80%, more than 80% weight is considered, weight for the age. More than 80% is considered as normal. If the weight for age is less than 80%, it means that the child is having protein energy malnutrition according to the IAP classification. Then you take the height of the patient properly in the standing position. If it is an infant who cannot stand or infant below 1 year of age, you will measure the length of the patient. Again, you write the current length, the expected length, and the percentage. So a child should have at least 95% of the expected length for the age. So if it is less than 95%, it is taken as short stature. Then don't forget to check the weight for the height. That parameter also is there. So weight, height, then weight for the height. That is for wasting. Then you take the head circumference and the mid-arm circumference. Mid-arm circumference is an age-independent anthropometric parameter. You take it in the age group of 1 to 5 years. So after taking all these, you plot all these in your growth chart also. So you can use the WHO growth charts and plot them in the growth charts, as well as write the percentages for weight, height and weight for height, and comment whether it is PM, short stature or wasting. Then next is the coming to the examination proper. After anthropometry, you go to the respiratory system examination. So usual cases of pneumonias in young children, it is a bronchopneumonia. That is, you will get findings on both the sides. You have bronchopneumonia, you have lobar pneumonia, you have interstitial pneumonia. So usually in small children you get bronchopneumonia. You can also get lobar pneumonia, but it is more common in an older child, or usually above 5 years of age. Okay. So in the inspection you can comment on the trachea, whether it is in the just by inspection, whether it is in the midline, whether the apical impulse is seen or not. And you always remember apical impulse is slightly different from adults. Up to 4 years of age, apical impulse is in the 4th space. After 4 years, it comes to the 5th space. And up to 4 years, it may be 1 centimeter in the midclavicular line, or it may be 1 centimeter inside the midclavicular line, but it is in the 4th space. Then you look for the accessory muscles of respiration, whether they are working, intercostal, subcostal retractions, then the nasal flaring, then visible scars, veins, all that you know. Then palpation. For palpation also, you palpate for the trachea, whether it is in the midline or slightly shifted to the right also is normal. Then you look for the chest expansions. That is not always possible to measure the chest expansion and hemi expansion in small children. So an older child who will cooperate with you, you can look for the chest expansion at the level of the nipples. Otherwise, you say that chest expansion I couldn't measure because the child was not, I cannot because the child is small and cannot cooperate. So then, so that is in palpation. So all the other parameters also you have to look. So trachea, apex beat, chest expansion, hemi expansion, and then you palpate for the vocal fremitus also. When the child cries, child may not say one or 1, 2 or anything, but when the child cries, you can feel the vocal fremitus on both sides. Percussion also, normally if the child cooperates, you can do the percussion. Resonant note should be there. If it is impaired note, it's likely to be a consolidation, and if it is a stony dull note, it is likely to be a pleural effusion. Then the auscultation, bilaterally air entry, whether it is equal or whether the air entry is reduced on any side. Then look at the breath sounds, normal vesicular breath sounds, and sometimes you might get bronchial breathing over the trachea. Since the trachea is shifted slightly to the right, you may get a bronchial breathing in the right infraclavicular region also, which is normal. Then you look for the added sounds, that is the wheeze and the crepitations. Wheeze or rhonchi and crepitations you look. Then other systems also you look for. Usually when there is sepsis or a pneumonia, there might be a small hepatosplenomegaly associated with it. So look, that will be 1 or 2 centimeter liver. Even otherwise in infants, liver may be palpable up to 1 or 2 centimeter, which is taken as normal, and spleen tip also in infants may be palpable, which is passed off as normal only. But then you look for any organ enlargement, any abdominal tenderness, because once when I spoke about the symptoms of pneumonia, you also ask for abdominal pain. Abdominal pain, sometimes in lower lobe pneumonias, you can get abdominal pain. It has even been mistaken for some acute abdomen or acute appendicitis. So, abdominal pain you might find in lower lobe pneumonia. Similarly, chest pain. Chest pain, when there is pleurisy or pleural involvement, you can get chest pain also. Usually seen in lobar consolidation. In the initial stages, there will be pleurisy, and then you might get chest pain, and pleural pain is always aggravated on taking deep inspiration or by coughing. So now this is abdominal examination. Look for liver, spleen enlargement, any abdominal tenderness, and heart sound, CVS examination, because in a child with a pneumonia, always look for any shunt lesions, that is left to right, congenital heart disease, left to right shunt lesions like a ventricular septal defect. So look for that also. Then CNS, child will be irritable sometimes, because irritability may be because of hypoxia of respiratory failure also. Then look for the tone, the power, the DTR, any meningeal signs is there, neck stiffness, Kernig sign, all those you have to look for in a child who has got a pneumonia. Then Next is summary of the history and the findings. That is like, suppose we have a 1-year-old child, a girl child, who presented with fever, cough and fast breathing of maybe 4 days. So short duration of symptoms. 4 days, that means it's likely to be a acute infection, maybe viral or bacterial. So how do you differentiate from viral and bacterial pneumonia? In viral pneumonia, there it may start as a rhinitis with a low-grade fever, and this is followed by cough and fast breathing. But in bacterial pneumonia, it will be of sudden onset. It may be high-grade fever. Then there might be cough and fast breathing and chest retractions. But still clinically, it is not that very easy like that to differentiate between viral, bacterial. But still you say that you get high grade fever, then it's more likely to be a bacterial pneumonia. And in viral pneumonia, so nowadays we are seeing lots of viral pneumonias because lots of viruses are circulating in the community. We have respiratory syncytial virus, you have adenovirus and many other viruses circulating in the community. Small babies, infants, they come with rhinitis and with a low grade fever, and 2-3 days later they start coughing, fever increases slightly, and child will be having fast breathing, and when you look you will find bilateral chest signs, crepitations, rhonchi, all this may be there. That is viral pneumonia. So but this is a short history. Suppose the fever and cough is going on for more than 14 days, then we may suspect some other organisms also, like tuberculosis. If it is fever, cough of more than 14 days and it is not responding to a usual antibiotics, then only we will think of tuberculosis. So that is, they're not responding to your antibiotics, normal and usual antibiotics which you give for pneumonia. So this is a child who presented with fever, cough and fast breathing, and in this child there was no similar complaints in the past. Suppose this child had recurrent cough and fast breathing in the past, then you may suspect that is this child having any congenital heart disease with a left to right shunt like a VSD. That will be one thing. Then recurrent pneumonias, another possibility is like any congenital lung anomaly, any tracheoesophageal fistula is there, or is he having a GERD, gastroesophageal reflux disease, or sometimes children with a cerebral palsy or neuromuscular disorders, they have swallowing dysfunction and they will have recurrent aspiration pneumonia. Then primary immunodeficiency diseases, cystic fibrosis, all these children, they can have recurrent pneumonias. Even in bronchial asthma, you may get secondary infection, recurrent pneumonias, middle lobe pneumonias can happen. So this child has no history of similar complaints and it's a developmentally normal, fully immunized child. Then you will have to summarize and say, so history, summarize the history, and when you summarize the history, comment about the development and the immunization status. Then on examination, you find that this child is having fever, he is tachypneic, having respiratory distress. Then you find that there is decreased air entry with bilateral findings, crepitations, wheeze. And after that, you mention the nutritional status. Whether the child is having PEM, whether the child is having short stature or wasting, whatever it is. And then you put so summarizing the history finding, then put the diagnosis, provisional diagnosis as a, because bilateral findings are there, you will say it is a bronchopneumonia. And then if there is PEM, then you mention PEM also after that. Bronchopneumonia, grade 1 PEM, like that. Then differential diagnosis for bronchopneumonia, we can put it as a bronchiolitis or a viral pneumonia or bronchiolitis. Okay, so that is how you go about presenting the case for the examination. Then you will be asked, how are you going to investigate this child? So, okay, this is bronchopneumonia. What are the investigations you are going to do? So, then you will say, I will look at the complete blood count of the patient. So, if it is a bacterial pneumonia, there will be neutrophilic leukocytosis. If it is a viral pneumonia, it might be lymphocytic counts. Sometimes there may be counts may be low also. That is, total count may be reduced. That is some cases of viral pneumonias you may find like that also. Then you look at the CRP, C-reactive protein, which may be elevated in bacterial pneumonias. So, CBC, CRP. Blood culture also, I will take blood culture before I start antibiotics. But the chance of blood culture becoming positive is very less than 30% only, that I may get a blood culture positive, but I can take that also. Then chest x-ray you can take, and then other investigations like sputum culture. Usually we don't go for sputum culture, because you culture the sputum, you are going to get only the normal flora which is present in the oropharynx. So no need for doing any sputum culture. Then there are other investigations, like suppose child is having a pleural effusion along with the pneumonia, you may take a pleural aspirate and culture, or all those. But those are not routinely done for routine cases of pneumonia. You don't need all that. Then treatment will be antibiotics. So for you give ampicillin plus gram-negative coverage also, that is gentamicin will be given. There is supportive treatment also, oxygen inhalation, IV fluids, antipyretics and all. And so I'll usually you will be asked about the ARA program, where in the ARA program you divide it into no pneumonia, pneumonia and severe pneumonia. So in the patient who comes to us in the hospital is usually severe pneumonia cases. Okay, no pneumonia is just a cough and cold. So this is for actually the community health worker, this classification of no pneumonia, pneumonia and severe pneumonia. So no pneumonia is just cough and cold, the home remedies are there. In pneumonia you get fast breathing, along with that there will be chest indrawing also, but the child is having chest indrawing, but the saturation is above 92%. That means there is no cyanosis, child is very alert, active, and child can take oral feeds. He is not drowsy, he can take orally, he has got fast breathing, some amount of chest indrawing, but it is not very severe. That is that there are no signs of severe pneumonia like drowsiness or feeding difficulties there. In those cases, the health worker will be giving, at the periphery, he will be given amoxicillin for 5 days. Okay, so that is treatment for pneumonia. But then when you are asked, when you admit the child in the hospital, it is because he has got a severe pneumonia. Severe pneumonia means there is inability to feed, there is lethargy, there is drowsiness, sometimes seizure, stridor, grunting, saturation is dipping, it is below 92%, or if you don't have SpO2 facilities at the periphery, then it is taken as a severe, managed as a severe pneumonia. If you can't look at the saturation, you will manage it as a severe pneumonia. So these are the cases which are admitted in the hospital, and once the child is admitted in the hospital, you have to give a broad spectrum ampicillin. Gentamicin is the coverage which you give. So IV ampicillin or penicillin plus gentamicin, it is usually given for 7 to 10 days. And oxygen saturation, second is low means 92%, below 92% means oxygen is given. Then second line drugs also we are having, that is cephalosporins, ceftriaxone or cefotaxime plus cloxacillin is another drug which you may add as a second line drug. So this is about staph pneumonia. That is one of the organisms which cause pneumonia in children. Usually it will be, one is H. influenza, then the other is pneumococcus, that is Streptococcus pneumoniae. Then another organism is Staphylococcus. Then we have the Mycoplasma pneumonia. The Mycoplasma pneumonia is usually seen in older children. Above the 5 years of age, you can get Mycoplasma pneumonia. Then viral pneumonia, as I already told you, one is respiratory syncytial virus pneumonia. So in staph pneumonia, the peculiarity is that this disease is very, very rapidly progressing disease. Patient will be very much febrile and toxic, and it will progress. Morning you will be seeing the child, he will be having fever, he will be very sick looking, and by evening he would have developed respiratory failure or some other complication like emphysema. So it progresses very, very rapidly, and he will get complications like pneumothorax or pleural effusion or emphysema. And characteristic feature of staph pneumonia is small pneumatocysts will appear in the lung. Then in the history will be there skin lesions, pus points in the skin, either impetigo or abscess or boils or infected scabies, some skin lesion where the staphylococcus has infected, that will be there. Then After measles, when a patient gets measles, you know that debilitating disease, no, the immunity is compromised when there is measles. So post measles pneumonia means it can be a very severe pneumonia. So this post measles pneumonia which doesn't respond to the 48 hours, within you're not getting any response to your ambigenta, then think of staphylococcal pneumonia and immediately add cloxacillin. That is the dose is 25 mg per kg per dose QID. That is 4 times daily you have to give cloxacillin. And always remember, usually for pneumonia the treatment is for 7 to 10 days. But for staphylococcal pneumonia it has to be given for a long time, like 3 weeks. And suppose there is some complication like pus, empyema or a pneumothorax or something, that will be antibiotic therapy, that is cloxacillin. It will be given for up to 4 to 6 weeks. That is the duration of therapy for pneumonia. So once the child recovers from pneumonia, what do we do? This is the part. Once the child recovers from pneumonia, you call him back and then monitor the patient. So you have to monitor his growth, give him energy dense feeding. You will have to, if he's anemic, you correct it with iron folic acid tablets, give proper dietary counseling, hypercaloric diet has to be given. So all these have to be done, and follow up and make sure that he is given all the proper immunizations also. So that is all about a case approach to a case of pneumonia. Okay, thank you.